Good afternoon. Welcome back to the second part of the webinar session. As I already mentioned in the first part, that I will be discussing the training, monitoring, and evaluation of the mhGAP project in Kashmir in this second part of the webinar. This mhGAP project was run in collaboration with Health and Medical Education Department of Jammu and Kashmir, Royal College of Psychiatrists, London, and World Health Organization, Geneva. Just a brief introduction about my profile for people who will be joining this second part for the first time. In the first component of this presentation, I will be acknowledging the role of all the professional teams and organizations who contributed to the successful completion of this mhGAP project. I would like to thank the entire mhGAP team, my teachers, friends, colleagues, and family members who provided all support I needed in order to successfully complete this project. First and foremost, I would like to thank the faculty and the staff of Imam Hussain Al-Islam Hospital in Kashmir who supported us in conducting the field pilot training program before the launch of the main mhGAP project in Kashmir. This is the photograph of the Imam Hussain Hospital based in Srinagar, Kashmir. I would like to offer sincere thanks to Professor Rachel Jenkins, who is an emeritus professor of international psychiatry and research collaborator on behalf of WHO. It was Professor Rachel Jenkinson's session at one of the congresses conducted by Royal College in London which inspired me to initiate this mhGAP project in Kashmir. Professor Rachel was giving a presentation on the work of college in Iraq and how they successfully contributed to improving the mental health service provision in the primary care settings in Iraq. I would like to thank the Royal College of Psychiatry, especially Professor James U. Bailey, the immediate past president of the Royal College of Psychiatry and current chair Academy of the Royal Colleges of the United Kingdom at the international who I met at the International Congress of Psychiatry in Birmingham recently. Professor James U. Bailey was responsible for approving the proposal of the mhGAP project on behalf of the Royal College of Psychiatrists. This is a photograph of the Professor Sue Bailey and I'm sharing just a statement which she made as a president that as a psychiatrist, we straddle a unique blend of science and humanity, bridging the social, medical, and neurosciences. We strive to improve the mental health of individuals, families, and societies, and provide strong leadership throughout the care pathway. This is a photograph with Professor James U. Bailey at the last Congress of the Royal College in Birmingham this year. I would like to offer my sincere thanks to President of the Royal College, Professor Sir Simon Wesley, for his approval and signing of the MOU between the Royal College of Psychiatrists London and the Government of Jammu and Kashmir. This is Professor Sir Simon Wesley on the right side of the photograph. I would like to offer my thanks to Iraqi subcommittee of the Royal College of Psychiatrists London, especially Dr. Muhammad Al-Uzri. This is the photograph with Dr. Uzri outside the Royal College of Psychiatrists London. Dr. Uzri was responsible recently for formulating a new report on Iraq mental health which were launched in Leicester. I would like to thank the Royal College as they appreciated the uh, mhGAP project in Kashmir. The outcome of the project, it was mentioned in the last annual report of the Royal College of Psychiatrists, London. I would also like to offer my sincere thanks to Dr. Shekhar Saxena, who is the Director of WHO Mental Health and Substance Use at Geneva and head of the mhGAP project in the world, who provided guidance and technical assistance to mhGAP project along with his team. This is the profile of Dr. Shekhar Saxena published on the Mental Health Innovative Network. This is Dr. Shekhar Saxena chairing the 7th mhGAP Forum at WHO headquarters Geneva in October this year. This is the presentation in 2008 when the mhGAP Action Program was launched at the WHO headquarters. This is again a photograph taken at the WHO headquarters this year with Dr. Shekhar Saxena, Director of the WHO. I am pleased to share that it was announced at the mhGAP Forum that the mhGAP project in Kashmir was nominated as the most popular innovative project in the world from more than 120 nominations submitted by more than 100 organizations. I would like to offer my thanks to Dr. Rahul Shindia, who is the principal investigator for Prime and who attended the first mhGAP training program in Kashmir. He was also representing Professor Vikram Patel, who is a professor of international medicine, senior research fellow of Wellcome Trust Sangat Gawa, is also a member of WHO Expert Advisory Group on Mental Health, the World Economic Forum Global Agenda Council on Mental Health, and also a part of the Mental Health Policy Group of Ministry of Health Government of India. This is Dr. Rahul Shindia receiving the award on behalf of Professor Vikram Patel. Professor Vikram Patel was also present at the 7th mhGAP forum in Geneva this year, where I presented the findings of the mhGAP project in Kashmir. Professor Vikram Patel is a renowned personality and was also nominated uh, as among the most 100 influential people in the world by the Time magazine. I would like to acknowledge and appreciate the excellent support of the government of Jammu and Kashmir to the mhGAP project, which led to it be nominated as the best innovative project in the world, as mentioned earlier. This is the slide on the Mental Health Innovative Network showing the mhGAP Kashmir being nominated as the #1 innovation. This is the Mental Health Innovative Network team. This is a photograph with Dr. Shekhar Saxena, who represents WHO as Director of Mental Health Substance Use. And on the left side is Dr. Peter Singhal, Head of the Grand Challenges Canada, which is another organization collaborating with the WHO and London School of Tropical Medicine in the operation of the Mental Health Innovative Network. I would like to acknowledge the government of Jammu and Kashmir for excellent support for monitoring and evaluation phase of the mhGAP project 2014-2015. I would like to thank Honorable Ministers of Health and Medical Education, Mr. Chaudhry Lal Singh, Commissioner Secretary Health and Medical Education, Dr. M.K. Bandari, and Director Health Services Kashmir, Dr. Sumeer Muthu. I'm going to show the photograph of the Health and Education Minister, Mr. Chaudhry Lal Singh, giving the award of appreciation to CMO Gandharbal, Dr. R.D. Kasana, for excellent guidance and support and supervision to mhGAP trainees of District Gandharbal in the successful completion of monitoring evaluation of the mhGAP project despite massive floods in Kashmir, which led to the delay in the project for more than 6 months. The photograph shows Dr. Salima Rahman, who was the Director of Health Services, who initiated the mhGAP project and invited the team from Royal College of Psychiatrists. I would also like to acknowledge the role of the previous government, who led excellent support for training phase of mhGAP in 2013 and 2014. I'd like to thank Honorable Minister of Health and Medical Education, Mr. Taj Mohiddin, Commissioner Secretary Health and Medical Education, Mr. Ghazzafar Hussain, and Director Health Services, Dr. Salim Rahman, who initiated and supported this mhGAP project and invited the team from the Royal College of Psychiatrists, London. This is the photograph I'm going to show where Honorable Minister Mr. Taj Mohiddin is arriving at the inaugural function of the mhGAP, where he announced the signing of the MOU between the Royal College of Psychiatrists, London and Health and Medical Education Department of Jammu and Kashmir. Honorable Mr. Taj Mohiddin announcing the signing of the MOU between the Health and Medical Education Department of Government of Jammu and Kashmir Royal College of Psychiatrists, London, along with Director Health Services Salim Rahman and Dr. Peter Hughes, who led the first mhGAP team on behalf of Royal College of Psychiatrists, London. Dr. Peter Hughes discussing the mhGAP project and Memorandum of Understanding on behalf of the Royal College of Psychiatrists, London. This is a list of the organizations that have Memorandum of Understanding with the Royal College of Psychiatrists, London. And if you can see, the clear mention of Health and Medical Education Department, Jammu and Kashmir. There's another web page showing the various organizations around the world with which college has Memorandum of Understanding. I would like to offer my sincere thanks to Director Health Services Kashmir, Dr. Salimur Rahman, under whose leadership mhGAP project became possible and successful. Dr. Salimur Rahman on the right, receiving the award of appreciation. This is a summary of the achievements of the Director of Health Service Kashmir in 2012 and 2013. It clearly mentions that mhGAP Kashmir training program in collaboration with Royal College of Psychiatrists, London, with support from mhGAP, with support from W.H.O Geneva, as one of the key achievements of the Director of Health Services Kashmir. I would also like to acknowledge and thank the mhGAP trainers of 2013. This is a list of the trainers who came for the mhGAP training in 2013. This training was extended to 2 weeks, and in the first week, it was led by Dr. Peter Hughes, and in the second week, it was led by Dr. Sajjad Yusuf. This is the list of the trainers and their specialty. Most of them already had a significant experience in the delivering of the mhGAP. This is a photograph of the trainers in the houseboat in Dal Lake following the successful completion of the training in 2013. I would like to thank mhGAP trainers in 2014. Dr. Peter and Dr. Sajjad were part of the training in the first phase as well. We got Dr. Ryland and Pamela Moodley, who joined us in the second phase of the training in 2014. Word of appreciation being given to the trainers by the Health Service Dr. Salimur Rahman. I would like to acknowledge and thank mhGAP trainees who actively participated in the project and made it successful. These are the trainees who attended the mhGAP training in 2013. Trainees who attended in 2014. This is again a photograph of the trainees in the mhGAP training at the Regional Institute of Health and Family Care at W.H.O, where the training was being conducted. I would like to thank the Institute of Mental Health Neurosciences in Kashmir for their support in conducting the second phase of mhGAP training. I would like to offer my sincere thanks to Jammu and Kashmir Police, especially Mr. S.M. Sahai, Additional Director General Police, and Dr. Muhammad Muzaffar Khan, Director Police Direction Services Kashmir, and State Coordinator for mhGAP project in Kashmir. The Jammu and Kashmir Police provided foolproof security for the trainers who spent almost more than 2 weeks in Kashmir. Award being received on behalf of Mr. S.M. Sahai, Dr. Muhammad Muzaffar Khan, Director Police Duration Services and State Coordinator for the project, receiving the award of appreciation from Director Health Services Dr. Salimur Rahman. I would like to thank the NGOs, especially the Health Foundation and its chairperson Ms. Shafi, ActionAid India, Corporate Sector Jammu and Kashmir Bank, and TCS Cements for their support in making the mhGAP project successful. Mrs. Nigat Shafi, chairperson of the Health Foundation, at the inaugural of the mhGAP project in Kashmir. I would like to offer my thanks to all the supporting partners, which includes Director of Services, Royal College, World Health Organization, Prime, ActionAid India, J&K Bank, ActionAid, Health Foundation, TCI Cement, JK Police, participants, and Directorate of Health Services Kashmir. We'd also like to thank media for their excellent and responsible support with regards to promoting mhGAP project in Kashmir. These are some of the multimedia uh, articles that have been published in various reputed newspapers of the Kashmir. Dr. Peter Hughes giving the uh, press report to Mr. Asim, one of the journalists in Kashmir. Finally, I would like to thank the people of the valley whose support and prayers made mhGAP Kashmir a success, as depicted in the photograph of the Mental Health Network mhGAP Kashmir page, which represents a Kashmiri woman praying behind the lattice window, a symbolic representation intertwined with the success of the project. This is a photograph of famous Mughal garden in Srinagar, Kashmir. These photographs were taken by my friend and colleague Dr. Basharat, who is a consultant in medicine in States. Having acknowledged the role of all the people, professionals, organizations, and supporting partners, I will now I'm going to describe the MF project in 2013. These were the recommendations that were made by Professor Rachel Jenkins at the start of the mhGAP project in Kashmir. If you could see, she highlighted the important areas that needed to be taken into consideration in order to successfully conduct this mhGAP project. As she mentioned that it is important to establish mental health professionals at district level who can support and supervise primary care staff, and organize regional mental health professionals to support and supervise district level staff in her experience. It is these layers of support and supervision which are likely to be missing in Kashmir and which are likely to make a large difference to the long-term sustainability of the impact of the training. She also stressed that if they are to give adequate support, these higher levels also need training about mental health in primary care, as it is so different from secondary care. In order to address this phase, mhGAP has specifically devised training the training program, which specifically focuses on training these professionals, psychiatrists, and senior doctors with regards to supervision and delivering of training. She also stressed the importance of to monitor assessment, diagnosis, treatment, and referrals. This was the outcome of the meeting I had with Professor Sue Bailey, who was the president of the Royal College of Psychiatrists. This was following the proposal I took on behalf of the Director of Health Services Kashmir, Dr. Salimur Rahman. She clearly mentioned that we needed to proceed to a model as in Iraq, uh, as Dr. Peter Hughes had done quite a lot of work in Iraq as well and was leading the team of mhGAP project in Kashmir. She stressed about prioritizing the long-term plan, which we specifically focus on, and also sought the advice of Professor Dinesh Bugra, who is the president of the World Psychiatric Association. She also stressed the importance of having a formal role and having worked in Kashmir for the last 3 years as a consultant psychiatrist helped me to collaborate in monitoring this project, conducting training successfully. Having got approval from the college, this was the outcome of the meeting with the WHO Mental Health and Substance Abuse team in Geneva, which was endorsed by Dr. Shekhar Saxena, Director WHO. It was agreed that WHO will be providing technical assistance and access to training materials which WHO has given permission to print and use for training. WHO will be providing regular advice and support as the project proceeds, which they did. That I would be serving as a link between the WHO, Royal College of Psychiatry and the Kashmir government. And it was clearly agreed that it was important to discuss with the Kashmir government how the district mental health program and the mhGAP could be successfully linked in order to effectively contribute to developing mental health services at the primary care level, which was stressed by both Dr. Peter on behalf of the college and Dr. Yuta on behalf of the World Health Organization. This was the statement of the President of the Royal College of Psychiatry as we started the mhGAP training program. The Royal College is committed to supporting mental health care and mental health education across the world. Our volunteer scheme was set up with this core belief in mind, and I am very pleased that our college members are prepared to offer their time and expertise to volunteer in this way. She thanked Dr. Peter Hughes and myself for successfully initiating this training and hope that the participants found this experience enriching and rewarding. This is the mhGAP intervention guide devised by World Health Organization, which we use for delivering training, and which the doctors and the participants who were trained used it in their field work once they received the training. The mhGAP intervention guide is freely available to download on the WHO site. With regards to the mhGAP training, as mentioned, we received logistic support from most of the voluntary organizations, and we divided the training into four components. One was providing lectures, second was group discussion. In the second group, in this photograph, we see Dr. Muhammad Yusuf, who was the ex-HOD. He's a professor of medicine. I'm thankful to him. Dr. Professor Muhammad Yusuf attended the whole 5 days of mhGAP training in Kashmir, and this training led him to add a separate chapter on mental health in his book on emergency medicine in Kashmir. This is the group discussion being conducted, being supervised by Dr. Peter Hughes. This is the example of the role play which we used in delivering training. This is the PowerPoint presentation being given to the trainees. Having conducted the training, we asked the trainee to rank the various methods of training that we use to deliver the training, in which the most popular was the role play, which was ranked at number one, followed by group work, case discussion, lecture, and finally case presentation. This is the photograph of the mhGAP trainers evaluating the results of pre and post test questionnaire which we used in the training, as well as the overall feedback. The results were analyzed and all the results were evaluated with recommendations sent to Royal College, who then formally combined and combined all the results, analyzed them, and in the form of a report with recommendation, it was sent to government of Jammu and Kashmir. This is the covering letter of the report that was sent on behalf of Royal College of Psychiatrists, London, to Dr. Salim Rahman with copy to Mr. Ghazafar Hussain, Commissioner Secretary, Health and Medical Education. As you are fully aware that the Kashmir has been under political turmoil for the last 15 to 20 years, this slide demonstrates the number of cases seen at the Psychiatric Institute from 1985 to 2011. If you can clearly see the significant increase in the number of patients attending the psychiatric disease hospital between 1985 and 2011. Before starting the mhGAP training, we did a brief survey in which we asked all the trainees to analyze and to submit the number of cases that they have seen in the last 1 month. You see, most of the cases seen by the trainees were depression. Also, others which include somatization were 131, and then you can see the other disorders. 620 cases were the new cases, followed by the follow-up case with equal proportion of male and females. This is the slide presentation demonstrating the background of the participants in the first week of mhGAP training 2013. In the first week, we had a higher proportion of males attending the training. Majority of the trainees were doctors, followed by psychologists. Then we have students, we have social workers, and then we have other professionals. This was the participant background in week 2 of the mhGAP training. The females were more than males in the second week, and nurses constitute a significant part in the second week of the training. This is the mean pre and post test results. Uh, I think this clearly was improvement in the pre and post test results of the mhGAP training in both week 1 as well as in week 2. This is the feedback of the training. 46% felt it was clinically relevant and rated it in excellent and good. Similarly, they appreciated the structure and the clarity of the training. This is the overall score of week 1. This is the feedback results of week 2 with almost similar results, almost 40 to 55, 50% demonstrating that they felt that it was clinically relevant, was of good structure, and there was clarity of teaching. Again, overall score of the training in week 2. This was the poster presentation at the International Congress in London, presented by myself and Dr. Muhammad Muzaffar Khan, State Coordinator for the mhGAP. Having successfully completed the first phase of mhGAP training in 2013, in which we had participants from almost or whole of Kashmir. It's worthwhile mentioning that Director Health Services issued orders for doctors and nurses to attend from all 12 districts of Kashmir. Having completed the first phase of the training successfully, we then moved to the second phase of training in 2014. In the second phase, for the first day, we conducted a refresher course by the trainees who attended the mhGAP training in 2013, attended the session, and then gave their feedback and the experience about the use of the mhGAP training over the past 1 year. Interesting note, almost 65% of the trainees who attended the last year attended the refresher course. This is the feedback with regards to the refresher course by the mhGAP trainees. Again, focusing on clinical relevance, structure, clarity training, and overall training. This is the pre and post test training that we conducted for the trainees in 2014. In 2014, unlike 2013 training, we specifically focused mostly on the professional doctors and nurses of the district Gandarbal. The reason why specifically focus on one district this time was that it would be easy to monitor the impact of training and to effectively monitor and evaluate and provide supervision and analyze data to see whether the mhGAP training that we conducted was effective in producing results at the ground level. Again, pre and post test training in 2014. In 2014, the training was extended for 1 week and divided into two groups. This is again a feedback from group 1, focusing on clinical relevance, structure, clarity of teaching, and overall delivery of training. Feedback from group 2, this is the feedback that the mhGAP trainers gave with regards to the training conducted in Kashmir. I'm just going to read the first feedback from Dr. Lucy Porter, who was a psychiatry trainee at Mosley. She mentioned that the mhGAP training in Kashmir was a fantastic experience for me, through which I feel I have developed multiple skills, including the planning and delivery of training to a multidisciplinary audience. Our stay at the Regional Institute of Health and Family Welfare was great and could not have been more welcoming. I hope there will be further mhGAP trainings in the future. The feedback by Dr. Eleni Palizadu and feedback from Dr. Peter Hughes, in which he clearly mentioned that people had a lot of interest in stress condition, in somatization, suicide was an issue, and also drug and alcohol related problems. Dr. Eleni Palizadu was impressed with the participants' interest and motivation, as well as ability and eagerness to learn. She said she would be delighted to teach in Kashmir again. It was very rewarding. She appreciated the role of Dr. S.M. Kadri, who was the head of regional institute, the OB1, who was there present all the time to ensure all assistance to the trainers and trainees in the smooth conduction of the program. Following the successful completion of training and following her experience in Kashmir, Dr. Lucy Porter went on to conduct the mhGAP training in Zimbabwe. This is a report that she published about her experience in Zimbabwe. This, this was her answer in reply to one of the questions that she was asked that she was part of the mhGAP training program in Kashmir. As we clearly mentioned that the evidence base for global mental health highlights the high burden of mental illness in low and middle income countries, and therefore it is crucial that services for mental disorders are scaled up in a meaningful way. Lack of human resources is one of the major barriers, and creating solutions need to be implemented. There is compelling research that supports task shifting, where healthcare workers with a shorter duration of training can provide valuable care for people with common mental disorders, enabling them to lead healthy and fulfilling lives. For me, the mhGAP Kashmir training was an incredibly effective example of this. This was the feedback that was published in the one of the newspaper by one of the trainees. He mentioned that every day we learned something new, be it psychoeducation, psychiatric elements, or psychoeducation. We learned how few words of empathy can be better and effective than placebo used to pacify patients having somatization or disorders. We learned a beautiful new term, human placebo, where doctors become an agent of change by spending just a few more minutes with patients and not being mechanical. A galaxy of doctors, psychologists from Royal College of which I could not imagine of meeting even in dreams, taught basics of human care and love to be extended to patients having psychiatric ailments. This was the overall feedback by the trainers with regards to the program. They mentioned that mhGAP training is well designed, easy to teach and learn from, and very applicable. As one person commented, for her the course has been an eye-opener. I think the same can be said for some of the European trainers. Becoming aware how much can be done with little means and how much need and enthusiasm exists here to improve the lives of those with mental illness was at times a humbling experience. This was the paper that was published by the trainees who were basically a trainees in UK, attended the mhGAP training as trainers, especially Howard Ryland and Lucy Potter. I was just going to summarize the results that participation in the volunteering project in Kashmir provided trainees with real-world experience of many of the key issues in global mental health, such as the influence of cultural factors, stigmatization of mental illness, and the varying resource and structure of health system to respond to mental health needs. Trainees were also able to develop a number of generic competencies of relevance to their practice back in UK. This includes educational skills and the completion of workplace-based assessment. This was the feedback by the WHO mhGAP team from WHO headquarters Geneva. It mentions also about the mhGAP training in Manchester. It's worthwhile mentioning that before initiating the training, Dr. Peter Hughes and Dr. Sophie Thompson conducted two trainers training in London before the first phase of training, and in Manchester before the second phase of training. So most of the trainers who came to Kashmir had participated in the training the trainers workshops and were well equipped in using mhGAP intervention guide in delivering of the training. Having completed the first and second phase of training, in order to ensure better collaboration and commitment on behalf of all the collaborating organizations, we decided to get a memorandum of understanding signed between the Royal College of Psychiatrists London and the Health and Medical Education Department of Jammu and Kashmir. So I sought recommendations from all the relevant organizations and professionals with regards to the memorandum of understanding. These are recommendations suggested by Dr. Sheikh Hussain, Director at WHO. He stressed on focusing on stress, which is the issue in Kashmir, which has been under political turmoil for the last 2 to 3 decades. Focusing on psychological first aid training to healthcare, social care, emergency, police, and other staff members. So WHO has already devised psychological first aid training, and Dr. Peter Hughes also already conducted few first aid trainings in UK. So we are hoping to conduct a similar training for primary and secondary care workers in Kashmir. This is the copy of the covering letter of the Memorandum of Understanding. This letter was signed by Professor Sir Simon Wesley, who signed the MOU on behalf of Royal College of uh, Psychiatrists and as president of the college. And this is addressed to Mr. Ghazafar Hussain, who was the Commissioner Secretary Health and Medical Education Jammu and Kashmir, who signed it on behalf of the Jammu and Kashmir government. It mentions that we hope that this MOU will ensure the continued good relationship between us and that we can continue to support you as you arrange the training of health professionals in mental health disorders. These are the main components of the MOU that were agreed upon and signed by the two organizations. Capacity building in primary care delivery quality mental health services across the Kashmir region. Enhance accessibility of mental health care to rural areas. Provide good quality secondary care advice to primary care. Use of mhGAP intervention guide as one of the tools of capacity building. Use of principles of psychological first aid as appropriate. Enhance public education on mental health to combat stigma against mental health. Advocacy and respect for rights of patients with mental illness. Intersectoral collaboration to enhance mental well-being. Develop training in mental health at primary and secondary care level. Mental health training to providers of education and social work. And ensure high quality supervision, monitoring, and evaluation of all mental health care. Having signed the Memorandum of Understanding and completed the 2 phases of the training, we planned to initiate the monitoring and evaluation component of the project, which unfortunately was delayed due to massive floods in Kashmir. These are some of the photographs of the flood that happened 1 week after the completion of the second phase of training. This is the flooded uh, Srinagar city, capital of Kashmir. This is the aerial view of the flood in Kashmir. We almost lost 6 months before we could initiate the monitoring and evaluation. This is the recommendation that Professor Vikram Patel made regarding the monitoring and evaluation. He clearly mentioned that to evaluate the training, we need to focus on competency rather than just knowledge and attitude. He goes in detail as to how he is contributing to developing the competency module for the government of India, which then will be integrated and implemented across the country. He also stressed the role of using local expert and centers also to use the training as an opportunity to develop collaborative relationships between the primary and the specialist care, a key requirement for the successful integration of the mental health in primary care settings. As the implementation phase was delayed by more than 6 months, so we conducted several refresher courses for the mhGAP trainees before we started the monitoring and evaluation phase of the project in district Gandhabal. So these were the list of the primary healthcare centers in district Gandhabal that were chosen for monitoring and evaluation of the mhGAP training. Almost 14 to 15 primary healthcare centers were chosen. This is a photograph of the register that we printed for documenting the results with regards to monitoring and evaluation at one of the primary healthcare centers. The monitoring and evaluation phase was conducted over 3 months. So when we monitored about the number of cases that were seen by all professionals, both prescribing and non-prescribing uh, doctors. So this is the result of the number of cases seen in May 2015. Majority of the cases that were documented and seen were new patients in May 2015. This is the list of the number of cases seen in June 2015 and number of cases seen in July 2015. So this is a summary of the total number of cases seen in 3 months. See, majority of the cases were diagnosed with having depression, followed by PTSD, and then other mental health disorders. Of the cases that were diagnosed, 101 cases were provided treatment by the prescribing doctor, where 132 patients who were diagnosed by the non-prescribing doctors and other professionals were referred for further evaluation and prescription to either the psychiatric disease hospital or to the specialist psychiatrists who attended district Ganderbal 3 to 4 times a week. It's interesting to see from this slide that more cases were diagnosed by doctors who were non-prescribing than prescribing doctors. Having got good results with regards to number of cases that were diagnosed by the mhGAP trainees, the second important component was the supervision. So the supervision was divided into locus supervision. Locus supervision was provided by the psychiatrist who used to visit 2 to 3 times a week, and then we decided to conduct a distant online supervision. In order to provide the distant online supervision, we used the software which was devised by King's College London, medicineafrica.com. It's an online platform that connects doctors, healthcare workers, students, and teachers. It was built for the King's Third Somaliland program and has supportive programs to UK, Palestine, Kashmir, and Uganda. It can be used for education and training to improve clinical reasoning, teaching faculty to conduct better examination or learn research skills, strengthening or developing clinical services, giving tailored advice of development and evaluation of new services, and planning or collaborating on health service research or data collection. These are the various projects that Medicine Africa provided support. If you see, we have two projects from Kashmir. One is the Kashmir UK mhGAP e-supervision partnership, and second was the Kashmir UK Global Mental e-learning partnership, in which the medical students from various colleges of UK had an online interaction with the medical students of the Goa Medical College Srinagar, and they discussed all the modules of the mhGAP intervention guide. This is the web page of the Kashmir UK mhGAP supervision partnership. This is the list of doctors and psychologists in Kashmir uh, who received e-supervision partnership on 30th of May at Government Medical College, Srinagar. I'm thankful to Principal Medical College, Srinagar, who gave us permission to use the uh, library service of the Medical College, Srinagar. As this was being conducted for the first time, the mhGAP trainees did not feel confident in attending the online supervision at home, so it was decided to provide supervision in the library of the Government Medical College, Srinagar. Official request was sent by the Health Services to Principal Medical College, Srinagar, Professor Rafiq Pompari, who provided all support. So this is the list of the trainees and trainers who received and who provided online supervision. Again, the list of the trainees and trainers. This is the photograph of one of the tourist resorts in Kashmir. This is the web page of the second component of Kashmir Global Mental Health e-learning partnership, which I explained earlier. This e-learning partnership was run in collaboration with the Medical College Srinagar and International Voluntary Special Interest Group of the Royal College of Psychiatrists London, which was also responsible for selecting the trainers who came to deliver mhGAP training in Kashmir. This is Dr. Peter Hughes, the chair of the International Voluntary Special Interest Group, and Dr. Roxanne Keen Najat, who are responsible for coordinating this project from the UK. This is the photograph of Dr. Peter Hughes in Kashmir on the banks of Dal Lake, explaining to the medical students about the Psychiatrist interactive program. This is the flyer that was published, and it was basically published and distributed at the Pathfinder dinner in London. The aim of the Pathfinder dinner is to help and guide medical students to choose psychiatry as a career. This is the feedback of one of the students from Kashmir after successfully completing the online interactive projects. I'm going to read the feedback that Assalamu alaikum sir, I mostly had only positive experience from the experience. Firstly, it was good to talk to your peers from a developed country and compare our lives, ways of studying, patient interaction. It was a novel experience to know how much the developed countries are different from us, not only in infrastructure but in various ways. The problems we had in our countries were different: family setup, cultural diversity. It was good to come across different opinions. In psychiatry, it was great to know about a single disease from different perspectives, of similar disease in contrasting backgrounds, how administration of a developed country takes over the role of the family, and how much dependent the developing countries were on social contacts. Also, the stigma and awareness of different diseases in our countries. I think I got a lot of exposure from doing this project. Even the minor things had so much significance when we compare them in our countries. I also knew more about the disease and the approach to diagnosis. Lastly, I made a good friend who was always polite. I never had any issues related to time difference. Net connectivity was initially poor due to floods. Rest we managed, and I am really glad that I did. In future recommendation, improve the method of communication. The site has some issues when the speed was slow, making peers on the basis of matching times of being available. The rest it was great. Thanks a lot for giving us this opportunity. Finally, I would like to acknowledge the role of Mr. Saeed Uwais, who is a research fellow at mhGAP Kashmir. He was employed as a research fellow to collect data for the 3 months of the monitoring and evaluation. He is of psychology background with a diploma in computer software, and he basically is based in Ganderbal, which made it easier for him to collect data from the most of the primary healthcare centers based in district Ganderbal. This is Dr. Mr. Owais, and in the background you can see the mhGAP master chart at one of the primary healthcare centers. This is again another tourist resort in Kashmir. Having successfully completed the training, monitoring, and evaluation, I'm going to basically describe the role of the mhGAP forum. The vision of the mhGAP forum is to provide effective and humane care for all people with mental, neurological, and substance use disorders, with a particular focus on the poor and the vulnerable ones in low and middle income countries, by improving service delivery, reducing the treatment gap, and increasing financial and human resources for the mental health care. This is the mhGAP forum in 2015, where I represented my institute. With regards to mhGAP action program, it was adopted by the WHO in 2012 in the fourth meeting of the mhGAP forum. Just going to briefly mention the various points of the action plan. It's specifically focused on the comorbidity with physical problems and coexistence of mental disorders, linkage of mental health with HIV/AIDS, a reference to discrimination and disabled people, the linkage with social determinants of health, nutrition and environmental aspects, inclusion of spirituality as a dimension and the concept of recovery, quality aspect of health and social services and the concept of culture, acceptability and inclusion, Discussion of suicide not to emphasize only on the young, but in terms of vulnerable population. Intervention for suicide prevention for young people and research component to add more information on models being implemented on scaling and integrating mental health care into primary health care. Role and support of caregivers and families. Issues of important parallel roles of NGOs. Mental health issues in women and girls. Mental health issues in children and the role of e-mental health tools in implementation. There were certain issues that were raised in that initial discussion. They mentioned that there was exclusion of epilepsy. Too much focus was on mental disorder rather than overall mental health. They are weak linked to WHO stated priorities and international partners to be associated with all activities. Stigma was not strongly enough reflected. More positive rebranding of mental health was needed. Should reflect the mandate for greater integration and should include the importance of spirituality for well-being, which I think is quite important component, especially in the developing countries. Stress that we need to explore an alternative, more bottom-up, country-driven approach rather than simply trying to implement the Western model in the developing countries. To clarify as to whether all implementation options were optional or some were a priority, raising the priority accorded to mental health on the health and developmental agenda, and to make the action plan discourse more global than a Western public health model, focus on transcultural issues and potential value of other cultural models. This is the photograph with regard to statement made by various member states at the mhGAP forum in Geneva. So I'm going to basically mention about the statement by India, who was responsible for co-hosting the launch of the mhGAP action plan in 2012. Mentioned that India had the privilege and pleasure of sponsoring along with Switzerland and USA the resolution on mental health in Executive Board of WHO in 2012, so endorsed by WHO Health Assembly in 2012 and led to the development of Global Mental Health Action Plan. It stressed the importance of mental health, that it was the evolving threat of mental disorder. Action on mental health cannot wait till other problems have been solved, it will then be too late. It mentions the need for continuous treatment and regular follow-up. It stressed on depression, which was the theme of the World Mental Health Day in 2012. It mentions that the Indian government was focusing on revising the district mental health program for its effective implementation and was going to allocate significant amount of funds for the implementation of district mental health program. And it also welcomed the role of WHO in providing technical assistance, which it effectively provided with regards to mhGAP training program in Kashmir. This is the list of the international and national partners in the mhGAP forum in 2014, which included the Royal College of Psychiatrists, London, other organizations, as well as Institute of Mental Health Neurosciences, Kashmir, India. This is the slide I often use to show the need for equality. This is a photograph taken from the inside of the Concorde plane. The significance of this photograph is that it is the only plane which has got no class distinction with regards to service provision, which is the fundamental principle of our project. This is the photograph of the famous Hazrat shrine in heart of Srinagar called Hazrat Shrine. It's on the banks of the lake. This is again one of the slides of in Kashmir. I would like to thank everyone for being patient with my presentation, and If you have any queries or any feedbacks, feel free to write back to me on my email. Thank you.